Functional anatomy of the knee and leg. This is Mary Lloyd, Ireland. I'm going to walk you through anatomy of the knee, and then we'll move down to the calf and talk about some of the anatomy of the compartments of the calf. I would like to credit Primal Pictures for some of the great anatomy software that they've produced. They have several different products. There's an interactive knee and an interactive functional anatomy. And I think they give us a really good visual, being somewhat three-dimensional and showing muscles and their activity across joints. So this is a resource that I would suggest if you are needing to teach anatomy of the knee, that you utilize this for your students. It's an English company, Primal Pictures, and the .com is shown. I have no financial interest in this company or others. Disclaimer. Looking at the lower limb model, the lateral view, you can see the right hemipelvis up above, and we'll add the muscles, and I think this is very important to understand what the muscles do, where their origin insertions are. And this is much more exciting than looking in a textbook. So you can see we've added our hip abductor above, we've added the perineals down below, and the toe extensors. And then we add the great toe extensors, add the hamstrings. Hamstrings are a two-joint muscle across the hip and the knee, having significant function for balance and for knee control, primarily a knee flexor. Lateral compartment of the calf. And then we'll add the biceps femoris, lateral hamstring, add the hip flexors, rectus, sartorius, gluteus medius, add the quadriceps, gluteus maximus, add the rectus femoris anteriorly, and the anterior compartment of the calf, and the Achilles tendon, gastroc-soleus. The important IT band overlying the quadriceps. And then we go into the dermatomes of the lower extremity, sensory dermatomes. When we get the medial aspect of the knee, again a right knee, add the tendons, important stabilizing tendons. Add our musculature, adding the medial hamstrings, sartorius, gracilis, semimembranosus, and then the last one, semitendinosus. Add the quadriceps anteriorly, vastus medialis obliquus, rectus, calf musculature, hip musculature, and then the inside sensory dermatome distribution. Looking for the front, again adding the tendons at first, capsular attachments, then adding the muscles. I think this is a very good way to teach and understand the functional anatomy of our muscles. Sensory dermatomes. And as we look in the back, again at the knee, putting in the PCL, medial collateral ligament, lateral collateral ligament, stabilizing structures of the sacroiliac joint. Now the calf down below, the posterior tibialis, peroneus brevis and longus, thinking of muscles as agonist, antagonist, those at the foot being inverter posterior tib, eversion, peroneus longus. At the knee, the popliteus muscle, which is the upside down muscle. The origin is distal, insertion is proximal. Get your medial hamstrings, biceps, another medial hamstring, gluteus maximus above, IT band, and the sensation. So when we think about the activity of the muscles, the green is the muscle contracting, the red is relaxing. So think about the agonist-antagonist of rotation of the knee. See, the biceps is an external rotator shown on the left, and the medial hamstrings, sartorius, gracilis, semitendinosus, are internal rotators of the tibia, and you can well see their origin coming off of the pelvis, the anterior superior iliac spine of the sartorius, the most superior of the hamstring muscles, the longest muscle in the body. It's the tailor's muscle by history, named after seamstress and tailors who would get in a position that would irritate that muscle. And you can see the semitendinosus inferiorly and the gracilis in between. So think about the agonist-antagonist function of these muscles. Similarly, flexion extension of the knee, hamstrings and the Achilles in the back, active in knee flexion and foot plantar flexion. And then anteriorly, we have the we have the quadriceps anteriorly activating for knee extension. Looking anatomically, the rectus femoris coming straight down, underneath that the genu articularis. There is a medial muscle, the vastus medialis obliquus, and laterally the vastus lateralis. The IT band comes to insert on Gerdy's tubercle laterally. The other patellar stabilizing ligaments are the most important is the medial patellofemoral ligament. There's also a ligament that attaches from the patella to the tibia medially as well as laterally. The important patellar tendon, which actually is a ligament because it attaches the bone to the bone, attaching the inferior aspect of the patella to the tibial tubercle centrally. And then there also is the lateral patellofemoral ligament and then the IT band blending in there. This is a cadaveric dissection. There's a very thin fascia over the vastus medialis obliquus. As we dissect into the knee medially, there's a very thick plica that the forceps are pulling on. This plica is a normal anatomic structure that is rubber band-like, and it can create pain in some individuals rubbing on that medial femoral condyle and cause some injury to the non-articular portion of the medial femoral condyle in the medial gutter. And then you can see here we evert the patella. The thickest articular cartilage in the body is behind the patella. This is the fat pad. The yellow in this cadaveric dissection is the fat. So you can see how far up the suprapatellar pouch comes. And when we see people with effusions, they have significant swelling way above the patella. And that's because the suprapatellar pouch is way above the patella. Blood fills up, goes posteriorly, but you can feel it and see it more anteriorly. And it probably goes up a hand's breadth above the patella. Fat pad has the most innervation in the knee, and it connects to the plica medially. So when we look at this drawing, you can see the fat pad infrapatellar, which connects to the ligamentum mucosum, just in front of the anterior cruciate ligament. And then you have the medial patellar plica, or the suprapatellar plica, and that band effect can cause medial pain in the medial gutter, and can mimic a medial meniscus tear. This is a normal structure occurring in about 80% of patients. We rehabilitate it and rarely excise it, but there are situations where it is a mechanical problem and can cause some wear on the medial patella, trochlear groove, or medial femoral condyle. The articularis genu comes in to elevate the fat pad in the suprapatellar pouch, rarely seen and not clinically significant. And the capsule goes all around the knee like a big balloon. That has the nerve endings. The menisci do not have nerve endings. The capsule has nerve endings, hence pain from a meniscus tear is not specifically in one spot. It's where that meniscus is flipping back and forth and tugging on the capsule. Lateral view, showing again how high up the capsule comes. There is fat surrounding the knee as well as the capsule. There's a bursa in the back, the synovial membrane in the back. Oftentimes people will be fixated on their Baker's cyst. This is actually a knee ganglion, if you will, that has fluid in it, and in adults reflects a problem with usually the medial meniscus, a tear in the medial meniscus, then a rent in the posterior capsule, and then a cyst forms where the fluid escapes from the knee. Take care of the knee problem, the Baker's cyst usually dries up and goes away. So when we go back to primal pictures, looking at the anterior aspect of the knee, you can see the patella centrally. There are different lengths to the patellar tendon, hence different contact pressures of the patella as it goes up and down the trochlear groove, much like a train on a track, or more appropriately, a lima bean in a spoon. Significant amount of tracking issues that we see, and this can be because of the shape of the patella, the trochlear groove, or the position of the femur underneath the patella. Taking away the patella, you can see the anterior horns or attachments of the menisci and the ACL back behind. The medial collateral ligament comes very distal. The lateral collateral ligament, lateral femoral condyle, attaching to the fibular head. Add the fat pad in. Add the patellar ligament or patellar tendon. Again, the genu articularis there centrally, which attaches to the fat pad. Medially, the sartorius coming in. Add the quadriceps tendon above, and the dorsiflexors of the foot and the calf. Add the entire quadriceps mechanism. When we see VMO atrophy, this reflects weakness of the entire quadriceps mechanism because that fascia of the VMO is very thin as opposed to thicker fascia overlying the other parts of the quadriceps. Add the IT band laterally, inserting onto Gerdy's tubercle. Add the arteries and veins. Medially, coming out from the hamstrings are the important branches of the infrapatellar branch of the saphenous nerve. What we see with medial surgery and medial meniscus repairs, or we can see injury to those sensory branches with numbness even down to the medial malleolus. We try to dissect around these, but unfortunately sometimes there are some dysesthesias after surgery. These also get involved with medial plica, regional pain syndrome, and sympathetic involvement. Laterally, you can see the superficial branches of the peroneal nerve coming out. Prepatellar bursa in the front. This is more of a local issue. You can palpate that. It's not intra-articular. It's between the skin and the patella, patellar tendon. Superficial sensory branches. the veins, and then the sensory distribution about the knee. If we look at a bird's eye view, you can see the medial meniscus on the left. This has more capsular attachments with the deep meniscotibial and meniscofemoral ligaments. It is more C in shape, where if you look to the right, the lateral meniscus is more U in shape, and the anterior posterior horns come very close to each other. It is a more mobile meniscus. You can see the popliteal tendon posterolaterally. There are varying anatomy of how taut the fascicles are, connecting the lateral meniscus to the popliteus and lateral capsule. About 30% of patients there will be a ligament of Humphrey, which is anterior, connecting the lateral meniscus to the PCL, and a ligament of Risberg, which is posterior, connecting the posterior aspect of the lateral meniscus to the posterior aspect of the PCL. These can be quite large, and we can view those arthroscopically. The importance of this bird's eye view is to understand the functional anatomy of problems with rotatory instability, such as if you tear your ACL. This is anterolateral rotatory instability, and envision the lateral tibial plateau going anterior in an ACL deficient knee or an ACL tear. But if we think about the functional anatomy, think about what happens to that knee and the subsequent problems with meniscal tears and articular surface problems. Again, bird's eye view from the top. You can see the medial meniscus on the left. The intermeniscal ligament anteriorly connects the horns of the medial and lateral meniscus. You can see in this specimen the ligament of Risberg in the back and ligament of Humphrey more anteriorly. The lateral meniscus is actually on the left, and you can see that it occupies more of the tibial plateau. The medial meniscus on the right is adherent to the capsule, whereas on the left you can see the popliteus tendon in the lower left. And there's a marker at that level. And this is where the lateral meniscus has a lot more mobility than the medial meniscus does. Oftentimes MRI scans will read a anterior horn lateral meniscus tear, and this is actually where the transverse ligament comes into the anterior horn of the lateral meniscus. And you can see where that looks ligamentous in the front, on the front left-hand side. So it is rare to have a tear of the anterior horn of the lateral meniscus, and if you understand the anatomy, you can understand why the signal is abnormal on the MRI scan, because of that transition meniscal tissue to ligamentous tissue. And this also shows us the bird's eye view of the anterior cruciate ligament with its two bundles, anteromedial, posterolateral, as well as the posterior cruciate ligament. Another bird's eye view. Here the lateral meniscus is on the left, medial meniscus is on the right. A primal picture shot, and they have many more examples of this that are very helpful to learn anatomy, which is very visual. So we look at this from the top. Again, the medial side, medial tibial plateau on the left, lateral meniscus on the right. See the differences of how much of the plateaus are shielded by the meniscus, much more of the lateral side. This is also important if we're doing surgery for transplantation of the menisci. We have to know the anatomy, and size is an issue for meniscal transplants. They have to fit like a glove. So looking at the topical anatomy of the knee, right knee, patella anteriorly, you can palpate the patellar tendon, tibial tubercle, fibular head, Think about fibular mobility of the proximal tib-fib joint. Classically, the IT band will bother people over that lateral femoral epicondyle if you palpate right there. And then the joint line is easily palpable in knee flexion. The Scholem mechanism, as described by Smillie, the tibia externally rotates in terminal knee extension. And this is important for normal anatomy of total joints. We do want some rotation involved in the joint. When we do meniscal tear tests, such as a McMurray's maneuver, we are rotating the tibia externally for medial, internal for lateral, but it's that terminal knee extension where there can be differences and cause lack of full extension and external rotation, as should happen if you have an intra-articular process. Joint palpation with a knee flexed. If we have a meniscus tear, typically there will be mid-posterior third pain for a medial meniscus and mid-lateral pain if there is a radial tear or cystic lateral meniscus tear. In my experience, doing the McMurray's maneuver in hyperflexion and then externally rotate the tibia usually will reproduce pain in a posterior third medial meniscus tear. Sometimes external rotation will produce pain in medial meniscus tears. In the original description by McMurray, tibial rotation was talked about, but not internal or external. And then for lateral meniscus tears, hyperflexion and internal rotation will usually catch that abnormal portion of the meniscus and create pain. Thinking about the anterior cruciate ligament, on the top shows the bird's eye view of this. There are two bundles in general, the anterior medial bundle and the posterior lateral bundle. These are named for their attachments on the tibia. Anterior medial bundle is taught in flexion, as shown on the right. The posterior lateral bundle is taught in extension, and the anterior medial bundle is. Thinking about the PCL attachment, there are two bundles of the PCL, the anterolateral bundle and the posterior medial bundle, again named for the attachments on the tibia. The concept of degrees of freedom and rotation about the knee are very critical. It's the rotatory instability that causes problems from anterior cruciate ligament tears, from other ligamentous combined injuries of the knee. And you can think about the different planes. There's the axial plane of external rotation, distraction, and internal rotation compression. There is the coronal plane, medial lateral, flexion and extension. And then there's also the sagittal plane. Again, from the lateral view on the left, you see the bursa under the iliotibial tract, the iliotibial band. There are also bursa in the back of the knee, underlying the biceps. Understand the anatomy of the proximal tib-fib joint, the muscles there, and always remember to examine the perineal nerve, particularly in a significant knee ligament injury. Medially, you can see the bursas that are underneath the medial hamstrings. Good example of the medial hamstrings and how far distal they come. They're distal to the tibial collateral ligament. You can see that is deep and proximal to the hamstrings. The hamstrings being sartorius, gracilis, and semitendinosus, where the bursa, anserine bursa, pes anserine meaning duck foot, which is what the insertion of these three hamstrings look like. So you can have a bursitis problem there. You can also have a bursa underneath the semitendinosus, which is right above and has 5 insertions in the knee. You can see where the adductor magnus is and the attachment of the tibial collateral ligament proximally, medial retinaculum. So think about the medial view of the knee. Medial meniscus, the interosseous membrane shown down below, the superficial tibial collateral ligament, anteriorly, suprapatellar pouch and the fat pad, add the hamstrings posteriorly, the patella, medial hamstrings coming down, good example of the S. sartorius, G. gracilis, ST. semitendinosus, gastroc, arterial supply, nerves, again you can see where they exit, can be variation in the anatomy where they exit posterior to the 3 medial hamstrings. Superficially, most superficially the veins, sensation. So when we think about the medial aspect of the knee, importance of the medial epicondyle, the medial patellofemoral ligament, vastus medialis obliquus, the semimembranosus coming in well below, posterior oblique ligament, and the medial gastroc. Reconstruction of the posterior medial corner is necessary in grade 3 injuries or in injuries that involve detachment distally. Recognition of significant medial-sided injuries is very important, and they should be addressed surgically, acutely, if they are severe instabilities. So this posterior medial corner consists of the medial collateral ligament, superficial and deep layers, the meniscotibial and meniscofemoral ligaments, and the posterior oblique ligament runs posterior to the superficial medial collateral ligament, and it forms multiple bands attaching the posterior medial capsule to the semimembranosus and to the proximal tibia. Oftentimes associated with a contact ACL injury will be a medial-sided injury that needs to be addressed if there's significant instability of opening and valgus stress testing at 0 degrees, increased anterior drawer with the foot in external rotation. And this is where MRs can help us on the medial side, looking at the meniscus and any damage distal, which if it's more damage to the tibial side, then there are subsequent problems with instability and lack of healing of the medial meniscus if it's repaired, unless those posterior medial structures are addressed and repaired acutely. Later they may require reconstruction. Looking at the lateral side of the knee, take the patella away, add the menisci, add the interosseous membrane. Add the lateral collateral ligament, popliteus muscle. Again, this is an intra-articular tendon. The origin is distal, insertion is proximal. Fat pad anteriorly. Patellar tendon, gastroc, hamstrings, biceps femoris, quadriceps, IT band, arterial supply, venous supply, the important nerves, understanding the anatomy and course of the peroneal nerve behind the fibular head, branching, check for sensation of the top of the foot and dorsiflexion after acute knee injury. Superficially, veins, and then the skin, and where to palpate for problems. So when we look at the lateral side, lateral gastroc, popliteofibular ligament, popliteus, tendon, and the fibular collateral ligament. Posterior lateral corner injuries need to be diagnosed acutely if there is opening in varus, if there is a reverse pivot shift, there's an external rotation recurvatum sign, or a positive dial test. You must think a significant acute posterior lateral injury, typically contact from the medial side or a hyperextension injury. So the posterior lateral corner consists of the fibular collateral ligament, the popliteofibular ligament, posterior lateral capsule, popliteus, which serves as a dynamic and static stabilizer, in the femoral attachment in the anterior popliteal sulcus, and then 2 centimeters anterior and distal to the fibular collateral ligament or lateral collateral ligament. It attaches on the tibia. The origin is distal, insertion is proximal. View from the back. Posterior cruciate ligament, lateral meniscus on the right, medial meniscus on the left. Popliteofibular ligament, lateral collateral ligament, laterally. Popliteus muscle, medial hamstrings, gastroc, biceps, medial and lateral heads of the gastroc. You can see there are originating posterior aspect of the femur, artery, popliteal vein, nerves, more superficial, the veins, and anatomically where you should palpate and what's running where. Posterior aspect of the knee, again the posterior lateral corner, the popliteal ligament, biceps femoris, fibular collateral ligament. There are bursas in these areas as well, usually not symptomatic. Knee ability, bird's eye view. Again, the central ligaments, the ACL and the PCL. The medial meniscus very well attached to the deep capsular structures. Lateral meniscus not so attached. The posterior lateral complex with the lateral meniscus not as well attached to the capsule. So we'll switch to the calf and talk a little bit about compartment syndrome. Obviously, there are 4 compartments in the calf, each housing different muscles. Tendons of the foot and ankle are easily palpable. In this more deep dissection, you can see laterally the superficial peroneal nerve. So it runs down to the dorsum of the foot. In the compartment anteriorly. In the back, where there are 2 compartments, the superficial and deep posterior compartment. When we think about anatomic sources of leg pain, got to think about the bone. Tibial stress fractures, more common than fibular stress fractures. There is a continuum of bone trauma, repetitive loading, that goes from stress reaction eventually to stress fractures. Bone scans are helpful, and now more commonly we get MRI scans if we're unclear if there is a stress fracture. Medial stress fractures will heal. The anterior cortex of the dreaded black line of the tibial will not heal, and oftentimes will require surgical intervention or change in the elite level of playing basketball. The periosteum can also be inflamed at muscular insertions, particularly of the tibialis posterior or the soleus. So you can have inflammatory tendon issues or overuse strains of the tendons about the calf causing pain. The other things that we think about, however, are the anatomic sources of the fascia. 4 compartments. There can be an accessory deep compartment, but typically there are 4. Proximal nerve entrapment can cause radicular pain, and chronic compartment syndrome can lead to neuropathy. These slides are courtesy of Mark Hutchinson at the University of Illinois, Chicago. Arteriosclerosis can lead to claudication, venous phlebitis, or thrombosis can occur posteriorly. This is a good example of a drawing depicting where these structures live. There can be popliteal artery entrapment from aberrant fascia of the medial gastroc. So think about that if a healthy person is developing claudication of their calf when they're running. This can be described as arterial endofibrosis and needs workup with a vascular surgeon, and usually ultrasound techniques are helpful for diagnosis. Different diagnosis of chronic leg pain in athletes is chronic exertional compartment syndrome. You can have muscle herniation that occurs naturally, which may actually help this. If the muscles are very tight, you may have athletes that have small little rents or holes in their fascia. I see this particularly in the anterior and anterolateral compartments. Shin splints are a medial tibial periostitis from overuse. You can have chronic muscle strain, more commonly of the gastroc, popliteal artery entrapment, and also think about referred issues from the spine. When we talk about compartment syndromes, they can be traumatic or exertional, as shown here. The exertional ones are the ones that we see in runners, repetitive sports such as soccer, baseball, a lot of running. The diagnosis is with compartment measurements by needle in the compartments before exercise and after exercise. Exertional compartment syndrome, they have no pain at rest. At a certain point they have pain. Sometimes it can be calf pain. Sometimes it can be numbness into their foot. It gets better with rest. Couple of pearls for athletic leg pain. If they have pain with initial impact, think about a stress fracture, periostitis, muscle strains, and tendinitis. If they have focal bone pain, think about stress fractures. If they have diffuse medial bone pain, think about medial tibial periostitis, focal muscle pain, a strain, or a hernia. If you can load their tibia and they have pain, think about strains, periostitis. Some people like using a vibration technique of a tuning fork for stress fractures. Pain at night should be a alarm to the practitioner that there could be a tumor. And pain on exertional, think about chronic exertional compartment syndrome, popliteal artery entrapment. pain at rest, nerve entrapment, paresthesias, that tingling, burning sensation in their feet after they've been running, chronic exertional compartment syndrome. And if it's an electrical shooting pain, particularly coming from the buttocks down to the foot, think about this being radicular in origin and think about a lumbar spine problem. History and physical, the pearls, diffuse swelling, deep vein thrombosis. A little less common with diffuse swelling of chronic exertional compartment syndrome. If they have a tendon rupture, such as a gastroc rupture, then you got to think you can examine them and determine this based on if it's an Achilles, no plantar flexion. Signs when you compress the calf, there is not passive plantar flexion of the foot. If there's a focal swelling, not diffuse but more focal, muscle herniation, ganglion, or tumor. 80% of compartment syndromes involve the anterior or lateral compartments. Much more successful surgically to release those compartments than the posterior compartments in a chronic exertional compartment syndrome problem. Obviously, with a fracture, you'll release them all. So when we look at this view of what's in the compartments, cross-sectional view, posterior compartments, gastroc and soleus superficially. Deep are the flexor hallucis longus, tibialis posterior, and flexor digitorum longus. Anterior, we have the peroneus longus and brevis, and more anterior, the extensor digitorum longus, tibialis anterior. Shows the nerves running through those compartments. The nerves in the anterior compartment, anterior tibial artery and vein, and the deep peroneal nerve as shown. Posterior compartment, posterior tibial artery, vein, and nerve. There are superficial nerves that we want to be careful of when we do releases. Posteriorly, the medial sural cutaneous nerve, and laterally, the lateral sural cutaneous nerve. The anterior and lateral compartments are shown. Lateral compartment, peroneus longus and brevis. There can also be a tertius in some situations. The anterior compartment, extensor digitorum longus, tibialis anterior, and extensor hallucis longus. The deep posterior compartment, tibialis posterior, flexor digitorum longus, flexor hallucis longus. Superficial compartments, soleus and gastroc, medial and lateral head. There can be another compartment described deep medial. Again, releases for chronic exertional compartment syndrome are not as favorable in posterior compartment syndrome as opposed to the anterior compartments. This is the surgical procedure that is done. We can do it through smaller incisions using the arthroscope to look for the superficial nerves to avoid damage to them, superficial peroneal nerve specifically laterally. This is a soccer athlete. Thank you very much for your attention. I hope this was helpful.